I am Dr. Ajinkya Nanavare from Emcure Pharmaceuticals. I welcome everyone to the No Thrombosis workshop in acute ischemic stroke. In the previous workshops, we had a very unique and interesting case discussions, and we are looking forward to have a fruitful discussion today as well. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course director. And it is my honor to introduce our faculty for today. Let me share my screen. Yeah. So I first welcome Dr. Subhash Kaul sir. Sir is senior consultant and stroke specialist at KIMS Foundation and Research Center, Secunderabad. Sir has been faculty for 27 years at Nizam Institute of Medical Sciences, Hyderabad. Sir has been a former professor and head at Department of Neurology and Dean at NIMS. He has more than 120 publications in national and international journals. Sir has been principal or co-investigator of several national or international projects, including the largest single center Hyderabad Stroke Registry funded by ICMR. He has been awarded by State Teacher Award by Telangana government in 2017. He has been past president of AP Neuroscientists Association, Indian Stroke Association, and Indian Academy of Neurology. Welcome, Dr. Kaul, sir.
Thank you.
So then I welcome, just a second. Our moderator for today, Dr. Rakesh Lalla, sir. He had some emergency at his hospital, so he will be joining little late. Sir is consultant and interventional neurologist at MediHope Hospital, Kalyan. He has multiple academic achievements, awards, and honors. Sir has more than 37 publications in various journals. Expertise are in mechanical thrombectomy for stroke, coiling of aneurysms, AVM management, carotid stenting, etc., and special interest in interventional neurology, stroke, movement disorders, and tropical neurology. Then I welcome our first expert speaker for today, Dr. Madan Mohan Gupta, sir. Sir is consultant at Neurointerventional Eternal Hospital, Jaipur. He has multiple academic achievements and has more than 9 years of experience as an interventional neurologist. Sir has performed more than 2,000 diagnostic cerebral and spinal angiograms and more than 500 complex neurovascular interventions like aneurysm coiling, stroke mechanical thrombectomy, intracranial and extracranial stenting, spinal and cranial dural AVF, etc. Sir has more than 10 publications in national and international journals, as well multiple national and international oral paper presentations. Welcome, Dr. Gupta, sir.
Thank you.
Then I welcome our second expert speaker for today, Dr. Sapna Erat Sridharan, ma'am. Ma'am is additional professor of neurology at Sri Chitra Tirunal Institute for Medical Sciences and Technology, Trivandrum. She has 60 publications in various journals and also wrote 4 book chapters. Her areas of interest are stroke, sleep medicine, and neurology in systemic diseases. Welcome, ma'am. So with this short introduction, I would like to hand over this session to our course director for today, Dr. Kaul, sir, for his opening comments and context setting. Dr. Kaul, sir, over to you.
Yeah, thank you. Thank you, sir, for starting the program today. Dr.
Ajinkya. Yeah.
Difficult name. Your name is difficult. It's not common.
Yes, sir.
It's a nice, little uncommon name.
Yeah.
So, this is a very important session. I welcome both our participants, doctors, for today's session, because here we focus on one case. And as you know that when we talk about trials and studies, these individual cases get dissolved in them. We never come to understand the particular case, the challenges it through, the opportunities it shows, the successes, the failures. They vary from case to case. As somebody said, the data and the knowledge comes to us collectively, but the patient comes to us individually. Patient doesn't come collectively. Patient comes individually, one by one. But the data is a collection of 10,000 patients. So therefore, it's very important to be aware of patient data, individual patient data, because that really gives the richness and the wisdom to deal with these patients one by one. So in that context, it's my pleasure to interact and listen to our today's speakers, both of them, as you have shown their CV. They're very well trained, well accomplished, and active in their field. So we'll start with Dr. Madan Mohan from Jaipur, interventionalist and neurologist. Over to you, Dr. Madan Mohan Gupta.
Sir, thank you very much, sir.
You can start sharing your screen, sir.
Thank you. Is my screen is visible?
Yes, yes.
So good evening, everyone. Thank you, Call sir and Emcure, giving me this opportunity to present my case over here. Oh, so this is a case of a 54-year-old gentleman who doesn't have any comorbidities. He is non-diabetic, non-hypertensive. And when we asked about any particular habits, he said he didn't smoke and he is non-alcoholic. He had complaint of sudden onset weakness of left side of the body, as well as facial deviation. He presented to our emergency in 3 hours. Immediately, our neurology team, I am also a part of that, we examined him and we found that NIHS was 13 and he is having 0 Wi-Fi power on the left side. So diagnosis was made clinically as a acute stroke. So we had MRI as well as CT facilities in our center. So fortunately, we did MRI, and on the diffusion weighted images, we noticed that there is a acute ischemic diffusion restriction in the right caudate, right putamen, as well as insular area. So it was a ischemic stroke. Immediately, we thrombolized him in the MRI gantry with the tenecteplase. We gave 0.25 milligram per kilogram, and we were planning for angiography. After when we planning for angiography, we were discussing with the family because this MRI diffusion is showing infarction in the M1 MCA perforator area, especially. So there is a high chances that this patient may have a large vessel occlusion, and we may need mechanical thrombectomy in this case if there is a clot. So after the discussion, we went ahead for the DSA because we have to give contrast for the CT angiography, and then we have to take for the DSA if there's a large vessel occlusion. In that period, he remained same clinically, and we performed the DSA. So first shoot, when I took from the right common carotid artery, there is a high-grade critical stenosis in the right internal carotid artery origin with distal dilatation of the carotid valve, as well as there is a thrombus filling distal to this area. But there is no good flow. Because we were planning for the DSA, as well as we were assuming this patient may need mechanical thrombectomy, what I did, we took a wire and did balloon angioplasty of this area and placed my guided catheter as well as aspiration catheter up to here. And we found that we have recanalized this vessel up to the ophthalmic artery origin. So there is a T occlusion over here, and it is a case of the tandem occlusion. After that, this was the significant stenosis with the distal thrombus. And in the first attempt, we could achieve TICI 3 recanalization in this case. And after that, we have waited for 30 minutes. We have not given anything, only just 2,000 heparin at the time of the procedure. And we did angioplasty. We have performed angioplasty with a 5 mm balloon. We were waiting if it recloses or again it may shut down the flow antegradely, then we may need stenting. But we were trying to avoid stenting in this case because he has been thrombolized. It is an acute stroke. We don't know what much area of infarction has been made in this 30 to 40 minutes area when we did this patient for the thrombectomy. So we waited and the result was good. And this was the aspiration clot which we have removed from the ICA. And this was the clot which we have removed from the MC with the help of the stent retriever. So large amount of clot burden was there, and this whole clot looks like a mix, means there's a clot with a red clot as well as some white clot. Immediately, patient had good recovery. You can see patient was able to move his left upper limb as well as left lower limb, and we discharged in very good condition. He was able to walk on the third day. And next, a CT scan was done, which shows small minimal reperfusion bleed in the right putaminal area and infarction obviously in the right insular area. But most of the area of the right MCA was preserved, and this area which we have shown in the diffusion restriction, that area is infarcted, but other areas were same. So in this case, we have taken two lessons, that we did a very good timely thrombolysis, as well as we took a decision to take this patient for the thrombectomy by assuming that he may have large vessel occlusion, as well as we avoid this stenting in this tandem lesion, and we perform the stenting after 3 months. In this case, his MRS is 0 now, and he is doing good clinical recovery. So MRA penumbral index is very important tool to recognize the penumbra. If rapid detection of penumbra is possible, then the treatment can be taken in the window period. IV thrombolysis, we are giving up 4.5 hours, and in the selected cases, we are doing mechanical thrombectomy in 24 hours. This is our team where we are working under chairmanship of Dr. Suresh Gupta sir. He is a senior neurologist from NIMS. Myself, Dr. Surendra, Dr. Arun, Dr. Tarajan. We are 5 persons in team neurology. Thank you very much.
Yeah. I think it's a big success. I must congratulate you.
Thank you, sir.
And what IV thrombolytic agent was used in this patient?
Tenecteplase, sir. TNK, tenecteplase. We gave around 16 milligram in this case, 1.6.
So, but the tenecteplase was not able to itself. It was not able to dissolve the.
Yes, sir. In this case, not. Sir.
So, yeah. No, although there is some data from Extend IA which has shown it, but then it may not happen in every patient. As a matter of fact, recently one study has come from All India Institute comparing tenecteplase versus alteplase, and in fact, in that study, they have found that there is no statistical significant difference between alteplase and tenecteplase.
Yes, sir.
So therefore, which means that we have to be always ready for mechanical thrombectomy. In some patients, it may get dissolved, but we have to be ready.
Yes, sir.
But one of the good things which you have done is that you have not waited. You have not waited. Let us see whether there is recanalization or not. Because by the time you lose the brain, there's no point later on doing it. By the time there is more damage to brain. And the other excellent thing which you have done is that you have tried to avoid stenting in the acute phase. Because most of the disasters happen because of the stenting in the acute phase, because of the double antiplatelet which you have.
Yes, sir. Yes.
And I have seen recently one patient from a very prominent hospital where they achieved recanalization, but within 2 hours there was a massive bleed in that area because he was stented acutely. But I just wanted to know from you that because you made a point towards that does it do they collapse angioplastic collapses in some cases after you initially do angioplasty, it again collapses? Does that happen?
Yes, sir. It happens in many cases. Reason behind is that when we are doing angioplasty, the clot disrupted over there as well as endothelium. So if we are not giving any antiplatelet on those cases and residual thrombus is there, it will try to collapse that artery. So avoiding that, many of the studies are showing that you have to do stenting in those cases. But if you have done very well angioplasty, just like I did a 5 millimeter balloon, generally, especially we are doing 3 mm balloon to enter it. and we are waiting for that because 3 mm is not giving suffice luminal dilatation to avoid the collapse.
So you should do a wide angioplasty. Luminal dilatation should be more, right?
Yes, sir. And another thing, sir, in those cases, which I have learned, just like you said, that with the collection of cases, what I learned, if you keep your guiding catheter above this stenosis and a good dilatation of the lumen, it may give prolonged dilatation with the guiding catheter as well. So you may avoid this. Actually, I have done around 30 cases of like these tandem lesions. Sir, I have not put a single stent in these cases because
then on what day you put the stent normally? After a week or so?
So no, sir. What I am doing, if there is a very small infarct, just like in this case, I have put a stent in this 3 months because he is having good recovery. But I will ask them to come in the 4 weeks. 3 to 4 weeks, 4 weeks in this case. But if there is a watershed infarct, I will try to do the stenting in the first or second weeks.
If it depends on the size of the infarct.
Size of the infarct, clinical recovery, as well as how is the collateral, sir.
What was the etiology of this tandem lesion? It was atherosclerosis or it was dissection?
It was atherosclerosis, sir, in this particular case.
But generally in tandem lesions, what is your experience? What is usually?
Sir, this is a plaque rupture from the ICA and that dislodges distally and causing slow flow and the residual clot formation in the ICA. That was my hypothesis in this case.
And that's true. So that must be the commonest combination. Atherosclerotic plaque in the neck and then causing same clot, a fragmented clot from that causing a distal obstruction also. Because,
sir, when I was taking my guiding aspiration catheter above, it was going smoothly with the thrombus coming out. But when I reaches into the ophthalmic artery segment, it was not going easily. I have to took my stent retriever and grasp the clot and then it will come out and immediately it opens up, sir. So
how common is dissection causing similar scenario? Not very common. Means tandem lesion.
Not very common, but I would say, sir, around 25% cases of the dissection presented like this also, sir. Yeah, I have done these dissection cases also, sir.
Okay. So I think this is a big success. What have been your difficult patients? You can tell us about your difficult. We have time, so you can tell us about some difficult patients which you experienced where the outcome may not have been good according to you. Can you share with us?
Yes, sir. Recently, I did around 2 weeks ago on the day of the Holi. One 81-year-old male came with the complaint of this one suddenly, and he was a non-case of diabetes and hypertension, right MC stroke. We were thrombolyzed immediately in 1 hour, sir. In 45 to 1 hour, we did thrombolysis with the tenecteplase as well, and he has not improved, man. And we took this patient for the mechanical thrombectomy. In the first pass, we opened the vessel very well, no doubt. But sir, he has not good recovery, sir. His power is only 1/5. So,
although you didn't waste any time, maybe his core from the very beginning was big, maybe. You know,
it is little aspect is around 6 on these cases, sir.
Yeah.
Because collaterals were not good, I think so.
Yeah.
And we did both the things simultaneously, same because. Sir, in these cases, we are very aggressive because whenever the stroke is coming, we always ready for each and everything, what we can do for the acute setting. But I realized that each and every factor, just like age, collaterals, your timing of onset, how the patient is coming, multiple factors are giving MRS after 3 months. We have discharged that patient today in good condition. He's conscious, but power is not recovered, sir.
You have you give heparin also to these patients. No, you have to give heparin.
Yeah, I am giving only diagnostic 2000 heparin if I am doing angioplasty or anything, sir. Because, sir, I don't want to propagate my thrombus in that area.
No, but if it is not a tandem region, if you are doing a pure,
I'm not giving heparin.
But it's not a must to give heparin in those patients. It's not must.
No, sir. Sir, heparin which we are giving to maintain our antigrade flow with our guiding catheter. What we are giving heparin in our bottles, just transfusion. We are not giving bolus in those cases because, sir, in my first year or second year when I came from the AIMS after my DM, I was giving 5,000 heparin and starting with the cases.
Even in the mechanical thrombectomy, the routine.
I am saying for the mechanical thrombectomy, what I stopped using this because I have realized when I am not using the heparin, after these antiplatelets, after this thrombolysis, after the mechanical thrombectomy, those patient has not so much of bleed. But in one case, I gave 5,000 heparin. He was on dual antiplatelet because of the PTCA, and I did a mechanical thrombectomy. He had reperfusion bleed. So I realized I should try. My try is going good. If I am successful in next 100 cases, I will try to publish it also.
So what I think you have got a good research mind, because you are doing something for the first time.
Yes.
What happened is that whenever our patient bleeds, and unfortunately bleeds happen, much against our wishes, then we always analyze and dissect what happened, what went wrong. So some of my mechanical thrombectomy patients bled, and then I thought that maybe because they give heparin. So I asked many people, interventionalists. That's why I asked you also. And all the interventionalists, Vikram, who did, and so many, they told me that they routinely give heparin, and usually it should not cause bleed, but they routinely give heparin. That's why I asked you. But you are the first one who is trying to change that practice, I think.
Yes, sir. What I am thinking in those rebleed, if there is a subarachnoid hemorrhage, it is due to, I think, tearing of the small perforators, and because of heparin or any other thing, it is giving that appearance. If there is a small tearing and you are not giving any heparin, there is very, very less chances that you may have this one, subarachnoid hemorrhage. But if it is a parenchymal bleed, I don't think so, sir. It may increase by those things that you are not giving heparin or not, because it will depends on your blood-brain barrier, how much infarction has been happened. That is my understanding.
So yeah, that is good. So the other thing is that when you know that when we do mechanical thrombectomy within 6 hours, we go by the aspect score also. One of the things is aspect score, that it should be at least 6. It should be 6. Means if it is 10 or 9 or 8, then it is not recommended as per the guidelines. Right?
Yes.
Means I don't know what is the logic behind it. Which means that if there's a very small stroke, then you don't do it. There should be some reasonable stroke. Aspect score is 6. What we call rule of 6. That the aspect should be 6. And so in other words, my question to you, what I'm trying to ask you is that does the size of infarct determine your selection for the patient? Which means you will not do it if the stroke is very small, and you will not do it if the stroke is very big. Does that make any difference to you as far as the core is concerned, size of the core?
Yes.
Is that a consideration, or that's not a consideration? On both sides, whether it's very small or whether it's very big, whether it's involving entire MCA or whether it's involving just like a lacunar infarct. In either way, does it make any decision for you to influence your decision making, the size of the core?
Yeah. If there is a large core with large vessel occlusion, we will not attempt, sir.
Okay.
There are two particular reasons which I think it has been proved, or in the future the public will say. Because, sir, there is a less chances of the recovery, which we were presuming, first thing.
Yeah.
Which we want to get from the mechanical thrombectomy. Second thing, there is a high chance of the reperfusion bleed or sudden appearance of cerebral edema, which may need early decompression, which should not, maybe saved on which may not be. Second thing. Third thing, sir, if there is a small lacunar infarct,
yes,
and there is a large occlusion is anywhere, like stenosis or the, we will try to open it up, because if you will not treat it, he may develop massive infarct, and when you will do that, and you will say, oh, half I damage and half I am saved.
But Madan, that is the whole most of the debates all over the world take place on this topic. So, LVO with the low NIHS.
Yes, this is going on.
But you are in favor of opening. You are in favor of opening.
I am in favoring of all the things we have to discuss with our all colleagues. Just we are having 5 colleagues. Our teacher is Dr. Suresh Gupta, sir, everything, and we are discussing with the patients also. We make cause harm also to you, because we are trying to save you. But
yes,
always we are not 100% that we are not God. We are trying. If you are agree, then we will go ahead. And sir, in our thinking that if we will try to avoid stenting in first 3 days in any stroke period, which is not so much bigger, then may be some beneficial, because the hot plaque situation is that it may cause reperfusion bleed and new stroke vice versa. Because sometimes antiplatelet stabilize the plaque and your stenting will give good idea to or good recovery to the patient. This is my understanding, sir.
No, that's true. That's true. My question is that just this is a very important topic because we face it every day. That let us say that if you are having a patient who is having a occlusion of the MCA, T-junction occlusion, but his NIHS is 2. He has mild dysarthria. So probably what I understand, you would like to do the procedure.
I would like to perform DSA.
Yeah.
And if there is a clot, I would say if we will try to remove it, you may save by the Broca's aphasia or a motor aphasia later on, or there's a 5% chances you may develop new deficit as well.
Yes. But you take that 5% chance after talking to family.
I will say, because sir, in this current practice, which we are dealing with this private sector, everybody wants very good result in the next 24 hours. He should speak, he should walk, because you did a mechanical thrombectomy.
Yeah.
We are not giving data. We are saying we are trying to minimize your damage, and maybe we may be fail, but we may succeed.
Yeah. But Madan, I have seen both sides of the picture. I have seen patients where we have not done anything and patient has developed a devastating hemiplegia 8 hours later. But I have also sometimes seen what you said, it happens in 5%. That means patient is totally stable and after the procedure he has developed some bleeding or something. So both happen. So
this is a very
different. As you rightly say, we have to take a shared decision making with the family and
family as well as team, sir. Because money is involved. Whenever the finance is involved in India, everybody want to close key. Is there any benefit to doctor, or they are saying right thing?
Yeah. But only thing is that sometimes we are lucky that once we give tenecteplase, and after that, when we go to DSA, we find that the artery has recanalized. So the patient has to be lucky, and the doctor has to be lucky.
So we are saying we are not doing anything because God has that medicine has done his work, sir.
Thank you, Madan. Thank you so much. We really learned. It was a very happy case, and thanks a lot for the discussion, for your experience, and all the best for your future endeavors. I'm sure you will do very well in future.
Thank you.
Thank you. So now it's my pleasure to invite Sapna to present her case from Shri Chitra Institute. You have already been introduced as an additional professor. Sapna, please present your case.
Thank you, sir. Is my slide visible, sir?
Yes.
Yes. You can move to full screen.
Oh.
You can start slideshow. There is an option on
Dr. Sapna, can you hear me?
Yes, sir.
I'm sorry, you're professor of neurology. I introduced as additional professor, but you're professor of neurology.
Yes, sir. Like I had given my old CV actually, sir. It's okay. Good evening, and taking the discussion forward where Dr. Madan and Dr. Subhash Kaul sir left, I will continue with the two brief cases. So
why don't you make it slideshow? Make it slideshow, go down so that we can have a better visibility.
There is an option.
Yes, that is it.
Yes.
Is it okay?
No.
It's not in slideshow still.
Oh, I've made it into slideshow, sir, actually.
Okay, we can see it though. We can see it. It is seen, but it is not in slideshow, but it's visible. If you are not able to get it, no problem. You can carry on.
Okay. So, I will just start with the status of bridging in acute ischemic stroke. So, what does the AHA guidelines mention in 2019? They mentioned that it may be reasonable to choose tenecteplase, single bolus, over alteplase in patients without contraindications for IV fibrinolysis who are also eligible to undergo mechanical thrombectomy. And ESO guidelines published in 2021 mentioned that for patients with acute ischemic stroke within 4.5 hours with a large vessel occlusion who are candidates for mechanical thrombectomy and for whom IVT is being considered, they suggest IV thrombolysis with TNK over autoclaves with a low quality evidence. So this evidence was gathered from extent 1K TNK trials. So I will briefly discuss two cases, which are very simple cases actually. First patient is a 56-year-old male who is a hypertensive on medications. No history of diabetes, coronary artery disease, or prior ischemic
No,
stroke.
Sapna, your slide is yours. We can't see your slide. You're on the last slide only. Please move the slide. We can't see it.
Ma'am, do you want me to share your slides? I can do that.
Okay.
Okay. You can stop sharing. I'll share your slides for you.
Okay. Maybe my network is not good. I'm not sure.
Yeah. Is it visible?
Yeah, it's visible and it is in the slideshow. It's a full screen now.
Okay. Yeah.
Yeah, go ahead, Dr. Sapna.
Okay. Sorry for that problem.
No problem.
The patient presented with acute onset right hemiparesis with global aphasia, onset at 6:30 a.m. He woke up normally and it was a witnessed onset. It was not a wake-up stroke. He arrived in the emergency department of our nearby hospital. On arrival, they had documented that patient was alert with an NIH 16. He had global aphasia and right hemiparesis. Blood pressure was 170 over 90 millimeters of mercury and the blood sugar was 201. So this was the image. In our center, we usually rely on a CT-based protocol for acute ischemic stroke, CT with angiogram, whereas in many centers, they prefer an MR over CT. This center was usually using MR-based protocol with a MR followed by a TOF angiogram. So this was the MRI film pictures which was shared with us. The patient almost within 45 hours of symptom onset, it had a fairly good aspects. So if you see the diffusion weighted imaging, there are changes involving the insula, a part of M2 and also M5. So fairly, and patchy M4. So fairly good aspects, 6 out of 10. And the flare, it was not showing any changes. The susceptibly weighted images, which is shown in the right side last column, it shows that there were some dilated vessels in the indicating that there may be a ischemic phenomenon. Next slide, please. And there was an MR angiogram which was available. So MR angiogram, you can see that I know the quality of images are not that good, but you can make out in the left side. In the left side, there is a distal M1 occlusion. Only the temporal division is visible. The rest branches of MCA are not visible. Whereas in the right side, you can see the M1 and MCA bifurcating into M2. So ICA is seen, whereas there is a terminal MCA, M1 MCA occlusion. Next slide, please. So the patient was thrombolyzed with tenecteplase with a door-to-nail time of 30 minutes. And the patient was shifted to our center for mechanical thrombectomy. In Trivandrum, there are few centers which are doing mechanical thrombectomy around the clock, and our center is one of them. So many of the centers where IV thrombolysis facilities are available, they shift the patient to one of the mechanical thrombectomy centers if they identify large cell occlusion. So the patient arrived within 8.5 hours, within 2 hours of symptom onset, around 45 minutes of thrombolysis at 8:30 a.m. On arrival, we found that NIHs had improved to 9. So patient had a recovering motor aphasia and right-sided weakness. Next slide, please. So because the patient had started rapidly improving, we performed a CT with an angiogram. The CT showed that there were some early ischemic changes involving the insula and M2 region and M4. And CT angiogram, to our cannot be said a surprise, but we found that the M1 MCA had recanalized. Next slide, please. So this is the maximum intensity projection images, which shows that the MCA, left MCA M1 had opened up, and there was a partially occlusive thrombus involving the superior division of M2. Next. And because the flow was anterograde flow was still there. The patient was managed conservatively, and this was the final infarct volume. Next slide, please. So we evaluated for the etiology of stroke. We couldn't find out in etiology despite patient undergoing 7-day Holter also. At discharge, patient had improved in NHS 4. There was a mild motor aphasia, right upper limb, lower limb drift, and he was ambulant independently. And 3-month NHS MRS was done. Patient had only an anomic aphasia. Next slide. And this is a case, second scenario, which is almost a similar case. 54-year-old male smoker with a past history of right PCA stroke in 2019. It was not evaluated except that he had undergone a CT scan and was started on single antiplatelet statin. And he reported a residual right homogeneous hemianopia since the time of stroke. He presented in our neighboring hospital with acute onset vertigo, dysarthria, and vomiting. When within 2 hours of symptom onset, on arrival, he had a left hemianopia, severe dysarthria, facial deviation to left, and right upper limb, lower limb ataxia. Then NIHS of 8 and MRS of 4. So moderate deficits with disabling deficits. Next slide, please. So the patient was immediately shifted for MRI. The MRI showed that there were few diffusion hyperintensities involving the cerebellum and early changes involving the left side of the pons, left hemipons. Next slide, please. And the flare images showed that there was a chronic infarct in the right PCA. Next slide. Okay. So the patient had undergone an MR TOF along with the parenchymal imaging, which showed that both the vertebrals were seen, but the terminal part of the left V4 was occluded and the basilar was not visualized. In addition, there was a symptomatic stenosis of the left intracranial part of ICA as well. So these are the two images which show that the terminal part of the V4 was not visualized and the basilar was also not visualized. Next. So this patient also underwent emergency thrombolysis with tenecteplase. There was a door to needle time of 35 minutes. Patient was shifted to our center for mechanical thrombectomy. And on arrival in emergency department in our hospital, within 4 hours of symptom onset, patient reported we found that patient had nearly completely recovered from the new deficits. Patient had an NHS of 3, only subtle dysarthria and hemianopia, which was pre-existing. So since patient had a near complete recovery, patient underwent a repeat CT angiogram. So CT angiogram showed that the basilar artery had opened up and we could make out the neutral PCAs as well. So here the etiology, there was a residual stenosis of the left vertebral artery. So the etiology was a large artery atherosclerosis. The patient was initiated on best medical management with dual antiplatelets after 24 hours after ruling out the bleed, since he had undergone thrombolysis, and he's doing well with no further recurrences. And at discharge, he had made a complete recovery. So a few points to ponder. Evidence for bridging versus direct empty in large vessel occlusion strokes. What is the impact of thrombolytic selection? TPA versus tenecteplase in clot lysis, clot migration and recanalization. And what is the current status shipping from a primary stroke center versus a direct presentation to comprehensive stroke center? I'm sure the moderator will be able to give us insights into these questions, which all the researchers are working on currently. Thank you.
Yeah, thank you. Thank you, Sapna. Before the moderator gives an insight into this, how do you look at all these 3 points? What is your take? What is your thought on it?
Sir, as per the recent randomized data, there is no superiority for bridging over direct mechanical thrombectomy. That is most of the what the most of the trials show. But there are some questions which still need to be answered in this. One is that most of the studies have patients, majority of the patients from the comprehensive stroke units, where you have facility for a direct mechanical thrombectomy as well. But what about the scenario in India and all, where the scenario which I described is the most common, that you have a few comprehensive stroke care units and majority of the centers do not have facility for a 24-hour mechanical thrombectomy. So we know that it is non-inferior, but there may be some scenarios where you can say that the direct bridging may be having an edge over direct MT as well.
No, as far as that point is concerned, Jinkya, have our moderators joined or not yet?
No, sir.
Okay.
Not yet.
Okay, that's fine, because we have to give chance to them also. No, otherwise they will think only I'm talking. If they come, then you please tell me. Huh?
Yes, sure, sir.
So you see, Sapna, the thing is that there are many studies done. I have reviewed this, and some studies are showing that they are same. There is no advantage of bridging versus mechanical, but there are some studies which are showing there is an advantage. At least 2 to 3 studies are showing there's an advantage, and many studies are showing there is not an advantage. But as far as the guidelines are concerned, as of today, guidelines can change. They are supporting bridging only. In fact, we are at such a stage now. Both will be right. The person who does bridging, he's also right, because that is what the guidelines say. And the person who is not doing bridging, he's also right, because many studies are showing that he is that it's almost same as. So the question of why do the people? What is the advantage of doing mechanical alone? Probably one of the things they think is that it may save time, but more than time, the bleeding complication may be less because you are not giving that IV thrombolysis. But on the other hand, I think both have their advantages. I would go for bridging. Why I would go for bridging is because there's a 30% chance I may not need a mechanical thrombectomy.
Yeah.
30% chance. 30% is not a small chance. Which means 1 out of 3, which means 3 out of 10 may not need. When mechanical thrombectomy you do, imagine that cost becomes 10 times more. 10 times. That is one reason why we would. Both your patients are showing the same thing. That you could have gone for direct also in these patients. Okay, we have got a mechanical. Why will we go for IV? We'll go directly for mechanical, and we would have never known. But we have huge data that whether it is alteplase or it is tenecteplase, 1 in 3 can be thrombolized, can resolve the occlusion. So that is why I would go for that. That was your question number 1. So I would say that of course, if you have, this is only up to 4.5 hours. After 4.5 hours, you have to go for mechanical. After 4.5 hours, I would not go for IV because then there's a risk of hemorrhage. What was your second point? So you raised 3 points. What was your second point?
Second was whether the selection of lighting that has a role, because till now the trials have tried alteplase in bridging. We all know that the problem with alteplase, when you're shipping the patient, that maintaining the continuous infusion is not very easy. So a bolus dose of TNK is easier to administer if you are planning to ship a patient.
Yeah, I think that also by and large we have got now Extend IA is the one which has addressed the same question, and they found they are equal. In fact, they found TNK is little better for that. Recanalization. So that is second. What was your third question? You had 3 questions you asked for moderators who are not present today. What is the third question?
And other was shipping from primary center versus direct presentation to whether there's a guideline should have a whether the guidelines or whether there should be a difference in the policy when you are considering patients directly presenting to comprehensive stroke center or a 24-hour MT center versus a primary stroke center.
No, I think we discussed that point. No, because what you are saying is that, I mean, the rationale behind your question is that at the primary stroke center, there is no choice. You have to give IV and then do drip and ship. Whereas in the comprehensive center, you have a choice. You can go for mechanical. So the guidelines should say something like that. But we have already discussed that. What are the advantages of giving IV first, even if he's in the comprehensive center, because he may not need that insurance. It may lies on its own, 30% chance. So in my opinion, I don't think. Of course, it finally depends on case to case basis. No, how each case is a little different. For instance, if there is a infarct which is slightly bigger, or if there's a infarct where there is already some hemorrhagic conversion, then obviously we'll go mechanical directly, even if it is within 4.5 hours. That also can happen. That happens. So that kind of guideline can be there, but with these statements, what are called disclaimers, that you can directly go with mechanical provided you have crossed 4.5, or provided infarct size is big, or provided there's a hemorrhagic or any other contraindication. I think that can be considered as a good suggestion. But one of the things I want to ask you, and I wanted to ask the previous speaker also, both of you can respond, is that, only for discussion, I also have my thoughts on it, but I would like to know your thoughts. That at the time when you have given tenecteplase, you have given it in the dose of 0.25, whereas the guidelines is only 0.2. So how do you routinely give 0.25? Is my first question. And do you give it up to 4.5 hours, or you also stop it at 3 hours only? What do you do in your real practice?
Sir, we are giving 0.25 milligram per kilogram weight. And we are giving now, initially we were giving up to 3 hours. But now with the recent trials on TNK, we have extended it to 4.5 hours as well.
So Madan, what are you doing?
Sir, we are using 0.2 milligram per kilogram in most of the cases.
And up to 3 hours or 4.5 hours?
Up to 4.5 hours, sir.
So Sapna has broken the rules 100%, you have broken the rules 50%. Because if you go by the... But both of you are correct in doing so, and I'll give you the logic. If you go by DCGI, as of today also, today's date, on 23rd of March, if you see the brochure which accompanies or if you see the guideline, it's to be given 0.2 milligram per kg body weight within 3 hours.
3 hours.
Now, I have heard that it has probably got the approval, but it has not yet come into the label of it will take some time, but the approval has been got. But we know, as you rightly said, that study was little outdated. That was done in 2015. The Indian tenecteplase study was done in 2015, and the paper was published somewhere a couple of years later, and the approval came in 2017. But things have changed much more, and now we know all over the world, everybody is giving 0.25 up to 4.5 hours. So even though Indian DCG has not yet given approval, at least on paper, we also are using it up to 4.5 hours, quoting the foreign data, quoting the TNK data, quoting the data in Canada, US, because if you take TPA, we didn't do any Indian study. They're also we went by the international study. So I think this is good. In both cases, you have given a good dose. It makes a difference. After all, there are initial studies where they have shown that 0.25 is the most optimal dose. At 0.2, they could not achieve all that. So one of the reasons why you could achieve the reperfusion is possibly because you gave 0.25. Quite likely, if you had given 0.2, it might not have been reperfusion. Quite likely. And then we would have said that tenecteplase has failed. Similarly, people have tried 0.45 dose also. But recently, there's a trial called NORTEST 2, and NORTEST 2 said that no, 0.45 is more, it can cause bleeding. Because NORTEST 1 said that 0.45 should be. And that was very interesting. NORTEST 1 said that 0.45 should be given for mild strokes, with an NIHS average of 4 or 5. But extend IA, intra-arterial, said that you have to give 0.25 with large stroke. So that itself was very counterintuitive. For small strokes, you are giving a big dose. For lacunar strokes, you are giving a big dose. And for large artery occlusions, you are giving a small dose. That was very counterintuitive. But that's what the trialists had done. And I'm very happy that NORD 2 corrected that anomaly, so to say. Because they clearly said that no, 0.45 may cause more bleeding. So stick universally to 0.25. So now we are happy. Now there is no controversy. 0.25 is the dose to go. 4.5 hour is the window. And at least 30% of our patients will get recanalized also. And rest 70% will need Dr. Madan's intervention. Okay. So I think we have almost finished the questions. You have any more comments or anything? Sapna, how has been the mechanical intervention at your center? We heard from Madan. I know your center is very active in endovascular treatment also. How is it going on in your center? Are you doing routinely in patients?
Our radiology team is doing the procedure routinely. And we also offered services 24 hours, like 24 round the clock, we offer mechanical thrombectomy services.
So what is the, I will ask you one question and later on I'll ask Madan Mohan also because we have got still some time, 2-3 minutes. So what is your experience in beyond 6 hours thrombolysis with mechanical? Are you doing it routinely or there are less patients or there are some challenges between 6 and 24 hours? Tell me something about that, your center.
Delayed window mechanical thrombectomy, we could publish our data last year in the Annals of Indian Academy of Neurology also. So we had around 34 patients in the last 7 years with delayed window thrombolysis. Delayed window mechanical thrombectomy, sir, not thrombolysis. So from 6 to 24
it was
hours.
How much delayed? 18 hours, 19 hours, like that also?
We like our mean around 7 hours, sir. Like it was not that delayed, like, but it was beyond 6 hours, beyond the guideline recommendation.
That is good. That's very nice. I will go through that paper. I have not seen it. I will go through. Madan,
so we found that there was actually when selection was based on a CT angio with perfusion or an MR based selection criteria was followed, we didn't find a difference in the 3-month outcome between the delayed window versus within window mechanical thrombectomy patients.
So Madan, what do you do? What is your longest window?
Oh, so recently, before 4 weeks, I did mechanical thrombectomy in 22 hours. So I will tell the whole story. And now you will understand what is the scenario. It is a foreigner who was a German journalist who came to visit India, and he got a stroke in Agra in the night around 8 p.m. On the next day morning, he came to our emergency, and in the afternoon around 12, he showed his CT scan. It was showing acute infarct in the right MCA hyperdensity. Sir, he was walking without dragging, means he was having around 3 power, sir, is the support. When he presented to our neurology chairman, sir's OPD, and suddenly his power came 0. And around 12 p.m. to 3 p.m. And at 3 p.m., he became totally paralyzed, means 0 F5 power, but he was conscious. Immediately, we did this one angiography, and it was showing distal M1 occlusion, just like MEMS case. Now, thing is was that it is around 5 p.m. when we took a decision in this case because he was an international patient, what to do. Now, the time of onset of stroke was around 8 p.m. previous day, and now we are discussing at 5 p.m. today. But his 0 power became 2 hours before. So what to do? But according to guidelines, we explained them in detail. A mechanical thrombectomy can be done in 24 hours because your parameters like diffusion flare mismatch is there, but you have infarct. We don't know, you may need decompression cranectomy immediately after that. You may have large reperfusion bleed, or maybe you may have some recovery. But
no, you did diffusion. You did diffusion flare mismatch, or you did CT perfusion or MRI perfusion.
So no, sir, I don't have the CT perfusion over here because rapid software is not there.
But no, you go by mismatch, MRI mismatch,
and a clinical presentation. Sir. But I am looking after the diffusion ADC especially, as well as flare, and trying to see the SWI to see how much is the collaterals are going on. These 3 images I am correlating, and try to see the penumbra. It is only the observation, sir.
You see the collaterals on SWI.
SWI is showing, sir, some this one hyper means blooming areas in the non-infarcted area.
Okay.
It will, please try to look on the acute stroke. When you will take SWI images, the areas where slow flow is there, means collaterals will not have the antegrade flow just like the MCA. They will give slow flow. That slow flow will give blooming on the SWI, and it may represent collaterals to you in that area, sir. So we were trying to see that, and we thought that there is some areas which we can save because they are educated and both are generalists. They gave consent. I took patient at 5 p.m. in the cath lab, and immediately in the first pass, I removed the clot. Sir, after 5 minutes, he was able to lift the limbs. And I discharged him with 4+ power. And I published, the Times of India has coverage within, I think, 15 days back, this story that German journalist has gone with the surgery with his life. So
Fantastic.
this is 22 hours, but I think the collaterals were saving him. And within 2 hours, the collateral was damaged. You are asking me, in the lacunar stroke, large vessel occlusion, they are good enough now. But after 4 to 5 hours, they may become like this.
Collateral failure.
Collateral failure. And
so
this 6-hour criteria is very good. My cases, which I have performed around 50 cases before 6 hours, having very, very good recovery. And after 6 hours, they don't have the very good recovery, which we are expecting. Just like we were saving some decompressive craniotomy, and we are giving 3/5 power, 2/5 power to them. This is the criteria.
Very nice. I think it's on a very happy note, optimistic note that we can conclude our today's cases. Thanks both Sapna and Madan. Both of you presented very well. Over to Ajinkya.
Yes, sir. Thank you so much, sir. It was a wonderful, wonderful workshop, sir, as usual. And I would like to thank and congratulate Dr. Gupta sir and Dr. Sapna ma'am for presenting those interesting cases. And thank you so much, Dr. Kaul sir, for your expert comments and your great practical insights. And we would really like to work under your guidance for many such future programs, sir. So with this note, we will close this session. Thank you everyone again. Bye-bye. Good night.
Bye.
Thank you. Bye. Thank you, ma'am. Thank you.